We're excited to have Anne-Marie Lange with us. She's a professor in population neuroscience and applied machine learning at the Queen Mary University of London. She's also an honorary research fellow at the University of Oxford and also the University of Oslo. Her research focuses on combining neuroimaging, clinical, genetic, and psychosocial data to study women's brain health across the lifespan. She leads the research group FemiLab, which started in Switzerland but now is based in the UK. The group works with both population-based and clinical cohorts and specializes in machine learning and statistical modeling of large-scale neuroimaging and health data. Anne-Marie has also experience in science communication. She has participated in a TED Talk and a BBC documentary, and now has recently published a book on the female brain. So we're so excited to have you, Anne-Marie. And
Thank you
yeah,
so much. That's a very nice introduction. It's really nice to be here with you. And yes, thanks for having me. I must take the opportunity to thank you for all the work you do. I was so impressed by everything that comes out of this community. Very grateful. And yeah, it makes me feel very positive about the future of women's health. So thanks for that. I can't really see who's here, but some of you know me and some of you probably don't. So just to give you a little bit of background beyond what Magda has already said, I initially trained as a clinical psychologist, and I did my practice specialization in clinical neuroscience in this hospital, rehabilitation hospital just outside of Oslo with beautiful view, where I worked primarily with stroke patients, TBI, before I moved into a PhD in cognitive neuroscience. So during my PhD time, I worked with collecting lots of MRI data in aging cohorts, similar to the work that many of you will be familiar with. We would scan people over time, maybe 200 to 300 people. So, you know, a lot of work. But it was only really when I moved into my postdoctoral work that things started to change quite massively in the field. And then especially with the UK Biobank. So all of a sudden we had data available from thousands of people. And for those of you who are unfamiliar with UK Biobank dataset, this is like a large health study in the UK with data from around 500,000 people, some of which have MRI data. And for me, this meant a huge change in how I worked. Everything from, you know, quality checking scans could no longer be done manually, definitely had to change statistical approaches and learn new methods. So it was quite a big change. At this point, I was in Oxford, where a lot of people actually are involved in the management of the MRI data in UK Biobank. As many of you already know, imaging data can be quite rich. So often you've got many different sequences yielding thousands of features, gray matter, white matter, all these things. And it can be voxels and it can be stats that you get from different brain atlases. But in the end, you often end up with quite a lot of data. And when you have thousands of participants, this can be quite overwhelming. And I think it's very helpful to have machine learning for these types of challenges because it can help with dimensionality reduction. So one example is hierarchical clustering, where you take all these features that co-vary and you group them based on the covariance in order to get features that are more statistically independent. Another example is brain age, which I will talk a little bit more about. Here you also end up with one measurement per participant instead of thousands of different imaging features, so it can be quite handy. I'm just going to try to move you a little bit out of the way. I think it's fine. So brain age prediction, I'm sure many of you are already familiar with it, but just very briefly, the concept is similar to biological age. And it is created using this regression model that predicts age based on only the MRI data. And then the input can be either tabular data, so stats that you get, for example, from FreeSurfer, or it can be run directly on the images, depending on which algorithm you use. So the idea is just that the model kind of learns how brains look across different ages, across the lifespan. And then you can get an estimated brain age gap, where you kind of look at the discrepancy between someone's chronological age and their MRI estimated age. And that has been shown now across quite a lot of studies to be a fairly sensitive marker for brain health and disease. So some of our brain age studies, just to give you like an example of how versatile it can be, we have used it in studies focusing on brain development and aging, also neuropsychiatric disorders. So, for example, we would often see that patient groups with dementia would have a slightly older brain age relative to what is expected for their chronological age. And we've also looked at stroke patients and traumatic brain injury where the same applies. We have also studied lifestyle and socioeconomic conditions, and of course, pregnancy and menopause using this measurement, as well as cardiometabolic health. I wish I could sort of go into all these studies because they are slightly different, but I cannot do that with the time that I have. But I will give you some examples where I try to sort of I don't know, show you a little bit about how the method can be used in various ways. So firstly, this is kind of how it all started. We looked at previous childbirths in a subsample in the UK Biobank cohort back in 2019. And it was really interesting because a number of previous childbirths actually was associated to brain age in midlife and older age in, I think it was around 12,000 women in this first study. And more children was related to a younger brain age. So now we're looking at, midlife and aging. We're not looking at before and after pregnancy. But what was interesting was that the most prominent effects were in regions that are known to change during pregnancy, from some of the really great studies from this community as well. And these are typically subcortical regions, which are estrogen receptors involved in social behavior, memory, etc. And these regions are also vulnerable to aging and Alzheimer's disease, which is interesting as well because we know that there are some sex differences in disease prevalence there. So in these studies that I've mentioned here, we're using these different types of outcomes, all are brain age, but they have slightly different input features. So I would say that generally we kind of see the same tendency across all the studies. Yeah, and it's kind of maybe the regional brain age study that you're looking at right now that was the most interesting for us because of the overlap with before and after pregnancy. Yeah, oops. But you can also look at it in a different way. So you don't necessarily have to do the regional brain age analysis. You can also just cluster volume features together with hierarchical clustering like we did here. I'm going to try to explain this graph to you. So we are looking at groups of women based on number of children. And each of the panels represent a cluster of brain regions that has been sort of identified based on covariance. So if you look at cluster 6, you see this sort of nice effect where the group of women without any children has sort of the lowest volume, and then it scales with more children. So it lines up with the plot on the slide before, but here the measure is slightly different. So again, we're seeing these subcortical regions pop out, and it's quite nice to see that it's sort of, yeah, it's the same across different studies. What is important though is that we only have cross-sectional data here, so we cannot be certain about causality, obviously, and I hope very much that in future we will have data from before pregnancy, after pregnancy, postpartum, and into midlife and older age, so we can really understand, you know, what these effects are all about. Moving on to another example from cardiometabolic health. This is something that I have been very interested in because we know that it's very closely related to brain health. We have seen links to brain age in many of our studies. And there's particularly one study here that I would like to just show you is from Louise. She was looking at this in the context of menopause status. We're still in the UK Biobank. And she found that blood lipids were higher in postmenopausal women, and that these measures of cardiometabolic health were linked to what we call white matter hyperintensities up to a decade later. And white matter hyperintensities is not the same as brain age, so this is a different measure. I think the Bianca algorithm is also machine learning, but I'm not an expert in that. But we are now looking at total white matter burden. And I think it's quite important because we have seen in other studies that the menopause transition seems to be a time of increased cardiometabolic risk in some women. And I think the results are indicative of this being a period where it might be especially important to monitor this in women. And yeah, white matter hyperintensities are common in older age, and it's something that you often see on MRI. But at the same time, they are also linked to risk of both stroke and dementia. So can be quite an interesting measure to look at in more detail, I think, when it comes to the menopause transition. We also have some interesting sex differences in these cardiometabolic health studies. This is a plot from one of Sivanya's papers where she looked at brain age gap, BAG, versus BMI, waist to hip ratio, and body fat percentage in the UK Biobank. And if you look at the sort of the middle panel, you see waist to hip ratio, you got the positive association both for men and women, higher waist to hip ratio, older brain age relative to chronological age, so higher BAG. But if you go to the right panel and you look at body fat percentage, it's opposite in women. So higher body fat percentage was actually linked to younger brain age. And Sivanya did some follow-up analysis and found that this was driven by the oldest group of women in the sample. And it's quite interesting because we have seen in, I think, at least there are some studies showing that higher body fat could potentially be protective in women. And it might have something to do with estrogen being produced by or in adipose tissue post-menopause. But at the same time, again, we're dealing with cross-sectional data, so it could also be a reverse causation. And in that case, it could be that weight loss is a symptom of neurodegeneration or something that is going on in the brain, even though it is a healthy sample. Some of them are already in their 80s here. One more important aspect, I think, of this plot is that you see what happens if you don't analyze men and women separately. You've got basically the association is 0 for body fat percentage when you put them together. So it's quite important, I think, to be aware that a lot of information could get lost if we don't look at them separately like we've done here. I don't know what's going on with the animation, sorry, but yeah, so we also follow this up in another study that was led by Savannah, where she looked in 2 different birth cohorts in the UK. And here you see how this association with BMI and brain age gap kind of it flattens out a little, and then it starts to do this opposite association at the last time point in these females in this sample. So I think it's indicating that there's something going on in older age, particularly. And interestingly, Savannah also found that the effects were more prominent in the ApoE4 carriers. So as you know, this is a strong genetic risk factor for dementia. So I don't know exactly what this means, but I think it's very interesting and should be pursued in more studies. But to come back to the modeling part of things a little, many of these studies that I've shown you now and that we have done, we are using a measure of global brain age. And I think that is quite handy sometimes, because we also know that the model is clever. So it will use all this intricate and detailed MRI data to give us one measure of brain health. But very often I think we're interested in regional effects. So we want to know what's going on. All the clinicians definitely do. They always ask, where in the brain is it, or what is the most important for the prediction model. And one way of sort of looking into this is what we call feature ranking. So you got this regression model, you got your outcome, and you can get a list of rankings basically for how the feature influences the prediction or the model result. But the problem with this is that the input data is always correlated when it comes to MRI. So volume in one brain region it's likely correlated to volume in another brain region in the same brain. So this is completely expected, but it creates issues statistically because these are not independent measure in terms of the information that they carry. This is not really something new. It has been talked about quite a lot in the machine learning world, and there are ways to improve this issue. So you can use clustering before age prediction, for instance. So you do sort of 2 things. First, you cluster all your features to make sure that you don't have thousands of very highly correlated features, but instead you have clusters with at least somewhat more statistical independence. PCA is another version of that, I would say, quite more or less the same idea. And I wanted to say that scikit-learn is a really good tool to use for this. I think, at least in my experience, the documentation is quite easy to read. They've got lots of different solutions for various things, and it can help even to read through their pages to try to understand if you have results from a model that can be hard to interpret. Python based, but it's really good. Yeah, this is an example of another way to sort of try to look into these models and understand what's going on. These are partial dependence plots, where you can look at one feature and see sort of how it influences the prediction in terms of direction, and also sort of when this effect kicks in. So you can, get quite a lot of information out of these types of different ways of looking at the features that go in. SHAP values is another one. I don't have the details of all of these things in my head at all, but I recommend really to just trying out different things if you're working with these types of models. Another option is to use normative modeling. That is a concept that is very similar to brain age, so you're still getting a measure relative to a normative trajectory. But here you're actually getting it regionally, so you get these Z scores or outlier scores for each region in the brain. And this is just an example, part of a figure from Savania's most recent paper. Very nice paper, recommend reading it. And also looking into these models, especially Andre Marquand's lab, they have some models that are publicly available. And I think there's even one where you can just basically plug your data in and get the outlier values out. You don't even have to touch code, I think. So quite something. Yeah, so just a recommendation if you're interested in the regional effects. Okay, so this is a very sort of strangely trivial thing, but it's extremely important to keep in mind that how well your machine learning model will perform depends fully on how well the input data can predict your outcome. I want to just show you an example from a study that I did some years ago where we were going to do brain age. And here I'm just looking at how different gray matter features correlate with age. So simple correlations. There are many, many features, and you see on the y-axis, you've got the correlation value. And this looks as expected. You know, most of them are negative with age. And the bottom plot just shows the significance threshold. And yeah, you see that many of them are above this. So yeah, all looks normal. And then we have fMRI, functional connectivity, where there just wasn't any correlation with age at all. That was very unexpected to me because there are lots of studies showing that functional connectivity changes with age, right? But in the study, we have quite a restricted age range, and it's not a massive sample either. Still a little bit strange, but that's just the data, it's just how it was. But in the end, this had quite large effects on how our machine learning models performed naturally. And I just wanted to give you an example of how it could look when we sort of try to change the sample size and the age range to compare the model performance. So for gray matter, you can see the y-axis is just the correlation between predicted versus true age. So the higher, the more accurate the model is. And then you've got these different bins of age range on the x-axis. And as you can see, the 46 to 80 is the largest age range or the widest age range where it performs the best. And then it sort of goes down. So the more you narrow in the age range, the less accurate it will look. That's just the nature of basically the R value as well. Like you cannot expect. Yeah. And for functional connectivity, you kind of see the same tendency here, but just look at the y-axis again, you see it just really didn't perform very well at all. So I think it's very important to just keep in mind that the model accuracy measures will depend on sample characteristics, age range, sample size, these kinds of things. And in the end, it's really difficult to compare performance across studies unless unless you have studies that are very similar to your own. So that it's hard to say like there is gold standard accuracy or predictive versus true age measure because it depends so much on the samples. And yes, so machine learning doesn't help at all when the features are not related to your outcome. Again, like I'm sorry, it's so trivial, but it has shocked me many times what comes out of these models, and I'm like, oh, it does kind of make sense because often we're looking at small effect sizes in our studies. And it's just to, yeah, as a reminder when you plan your studies, just to be aware that it will influence the model for sure. And this is also true in classification. So I'm just going to give you an example of this one where we try to predict parental status in a very big sample, actually. And if you look at the ROC curve, you see you've got the blue one for bag, brain age gap. So, you know, it's slightly above chance. So there's clearly something there, which is cool in itself, but it just looks very different than what we get when we try to predict dementia diagnosis in a much smaller sample. So this is just entirely related to how well the input data can actually predict the target variable. Very sort of, you know, basics, but still really important to think about when you plan studies. I think maybe smart to go and look at what people have seen in terms of effect sizes, and just keep in mind that, yeah, this might not look as good as you hope for. I wanted to talk a little bit more about the dementia prediction stuff, because we know that there are sex differences in Alzheimer's disease prevalence, disease trajectories, and also treatment eligibility and responses. And I think quite soon we will see more and more of AI models being sort of implemented in various clinical settings. We already have quite a lot of research centers and brain health clinics where research and clinical work is sort of starting to come together. And I think it's a good time now to try to understand how these models and predictions align with, you know, cognition, other types of symptoms in men and women. So that is something I'm working on at the moment, and I'm just going to show you, these are preliminary results, but coming back to this dementia prediction model again, which is based on, it's a binary classification. But what's nice about it is that it's sort of initiated, how do I explain? It's based on a model where Eston, my colleague in Oslo, has I think exposed the model to more than 100,000 scans, which is quite something. And then we can use the weights from this model to initiate our much smaller classification model, and the results are really good. And then we have, in addition to this held out test set, here you probably know how it has to be. You've got like training, and then you validate, and then you have to hold out some data to test on in the end. So here we got this held out test set, but we also held out a sample of mild cognitive impairment patients that the model has never seen. So these are categorized as non-progressive or progressive based on whether or not they move on to get a dementia diagnosis at some point. And if you look at this plot, you can see that the non-progressive MCI, female and male, of course, you see that at baseline, so the first scan, the non-progressive group has a lower dementia probability on average. And dementia probability here is an individual measure that all of the participants get that's coming from the model. So it's a probability estimate, basically, of how likely they are to be in the dementia group or the control group, more or less. So it goes from 0 to 1. So this looks as it should, right? And then for MMSE, mini mental state examination, this is a little cognitive screening tool. It's quite sensitive and used across clinics a lot. And here you see the same thing. The non-progressive groups have higher scores, which is a good thing, though, in this case. They score better than those that are progressive. And it's kind of interesting because this is quite a while before anyone is diagnosed, right? So already at this stage, you can see the differences at the baseline scan. When we look at rate of change, we see that the progressive group tend to change more over time, also exactly as predicted, more or less, because they are going to eventually get a diagnosis. And here I think there is a small tendency for a sex difference. So it looks like the women are potentially progressing slightly faster than the men. But here I have like a long list of things that I need to check because I don't remember exactly how it is now, but there's quite a lot of variance in terms of time between scans and these types of things. However, what is interesting though is that we do not see that difference when it comes to MMSE. So here, it's not so easy to see, but the error bars overlap more, and there aren't the same indications of sex differences in change in MMSE over time. So it's possible that there could be some indication of cognitive reserve in the women, that they are, they're progressing brain-wise, but not so much in their cognition. There are some interesting studies on this so I think there's a fair amount of evidence actually that women hold especially the verbal memory a little bit longer, even when the disease is progressing. Okay, so having said all of that, so all of this data is from ADNI, and we wanted to look at other clinical independent samples as well, because I think one of the sort of main issues is often that you try to predict outside of your own little sample, and it just doesn't work as well. So we're very lucky to have good collaborations with the Swiss memory centers, where they have like real clinical data, but they also have MRI for all of them. And what we have seen so far is actually that the model performs extremely well in this unseen data. So very little performance drop. I think that's really good to see. They might be fairly similar though in the end, these people, even though they're from completely different places in the world. But perhaps there's some, I don't know, education. There are many things. But it's a very good start, I think, to see that it can generalize like this. Here as well, it looks like it's just sanity checks, like the prediction probability is highest in the dementia group, and then in the MCI group is a bit lower. Subjective cognitive decline, even lower. Cognitively normal, also very low. And you can also see that there's not that much data, but it still kind of looks like we would hope. It makes sense. No sex differences here, it looks. And the same goes for MMSE. I think it looks like we would expect, with scores going down and at the lowest stage in the dementia groups. So I think one thing that I have been quite interested in addition to the predictions and the cognitive data in these types of clinical settings, are neuropsychiatric symptoms. And I just plotted this to see if there are any potential differences. And here we see anxiety. It's not very high at all across the board, so the scores are not generally very high, but there is definitely a sex difference. So the women come out with higher anxiety. And I would like to see, when I get some time to finish up all of this, I just want to see how things line up. I want to see at the same prediction level, do men and women differ in terms of cognition, psychiatric symptoms, X, Y, Z. And the reason I'm so sort of a bit obsessed with that is that I just worry that we are seeing maybe some type of biases in the clinics where we just assume that everything is the same for everyone at every stage, and I don't really think that's how it is in reality. Interestingly, though, we do not see those differences for depression. Okay, moving again. But when it comes to these types of studies, I think labels are quite the problematic, because they talk about ground truth in machine learning, and I feel that that's not really a very suitable way of talking about diagnosis. It isn't that straightforward. Many of them have more than one diagnosis. There's lots of co-pathologies. We also don't know exactly when they came in and when the symptoms began. There are all sorts of clinical assessments that are, between the patient and the doctor. And I think generally the data is just much less clear than research data that was for the purpose of research. I think the thing about labels is very important in other fields as well. For example, mental health. We don't really know exactly what depression is. We can have a lot of different causes. It can be linked to all sorts of different situations, anything from disease to trauma you've experienced, to hormones. It's just very, very complicated. And I think, yeah, just good to keep in mind that we're trying to predict something that humans created, in a sense. Let's see. In addition, we have all these various combinations of biological and environmental risk factors. I think it can be really tricky to disentangle at times. And also partly why I am interested in trying to look at things in different cohorts, preferably from different countries and areas, because that is also an issue, that we don't have very diverse data. And just coming back to this idea that these types of models will be implemented in the clinic, I think we kind of need to make sure that they make sense and predict equally well across different populations. So I just wanted to highlight some efforts that are going on at the moment. Savannah has this really nice new project called Diverse Brains, where the idea is to work on big data analysis with data from across the globe. And especially she will focus on intersectionality, so looking at these different types of variables and how they sit together. We're also collecting data in London, which is quite a diverse city, so that should be interesting to see how that goes. But the idea is to try to sort of make sure that we're not missing something, right? And when we are working with brain age, normative modeling, dementia prediction, we have to check that things are actually useful for everyone. Another project that I wanted to just show you that we've just started working on is a project on data from Northern Ireland. A very interesting part of the world because of the conflicts. And I think what we're interested in here is trauma and how it can influence genetic aging, cardiometabolic aging, endocrine aging, and also cognitive aging. And we're doing this in collaboration with Queen's in Belfast, where there's also a dedicated project for all the menopause variables that have been collected in this data set. So I think that, I'm a little bit drawn to looking at particular data sets where something is a little bit different, right? To see if it actually lines up with what we see, for example, in the UK Biobank, where they didn't experience this type of conflict. These types of things. I don't think there has been that much work done on women in this data set before. So I'm excited about this. We also have similar data sets that are available in the Republic of Ireland and the United Kingdom. So these are like longitudinal aging data sets with, I think the Nicola one in Northern Ireland has between 8 and 9,000 participants in it with follow-up data, very nice. They are, I think, above 50 though at recruitment, so we don't get the menopause transition for everyone, but it's still quite interesting in terms of female-specific variables as well, because we do have some in these data sets too. Yeah, we are also working quite hard at the moment on the UK Biobank data to look at similar things. So I'm hoping that over the next few years we will have a little bit more to show in terms of epigenetic age, these types of things that we're working on now in these women. So if you add it all up, I think the sample sizes are fairly big, and hopefully we can use some of these modeling techniques. And I think that is what I had, and I'm not over time. So happy to answer any questions you might have. I think I can, if you want me to stop screen sharing, should I do that now or?
Yeah, sure. It's fine. Mm. Yeah,
Thank you
thank you,
so much.
Anne-Marie.
Yeah. Sorry,
Yeah,
go ahead.
sorry. Yeah, no, thank you so much for this talk, Anne-Marie. It's so nice to hear about your research, but also these new initiatives about, like you're trying to look at diverse brains. And yeah, I'm so excited to know more about that. Um,
I have a really
and
kind of quick one. So when you were showing those the brain age models and the prediction of kind of conversion to Alzheimer's from the MCI group, you had like the separate bars for male and female. And I may have missed this when you described the modeling procedure, but are you training the models on both male and female individuals and then testing them separately on male and female?
Yes, basically. So it's in the model training, we are stratifying based on site, age, and sex. And then the plots are just done separately. So we get the prediction for everyone.
Mhm.
And the test. So it's all, yeah, it's both basically, yeah. So
Yeah,
the
because
idea
I
that
wonder, yeah,
yeah,
sorry, go
sorry.
ahead. No, I
Go
was just
ahead.
going to say some of the things that we found is that like if you train a model just in females and just in males, you get different mappings, right? So it may be that the model, and it could be that the model is biased towards one group than the other if there's a higher, if there's a stronger effect in one of the other.
Mhm.
So we've done a lot of like work in training and testing models that are agnostic to sex or specific to sex and seeing how they do on the other sex, because there is this
Yeah.
potential possibility that there's a variability in the mapping between brain and age or brain and MCI conversion in male and female individuals. Yeah.
Yeah, I think that makes a lot of sense. And I think we because we don't have so much data in the test
Mhm.
samples, I'm nervous of, cutting it in half as well.
Mhm.
Sorry, in the training data for from the ADNI.
Mhm.
But I think I'm also a little bit destroyed after having worked with the UK Biobank because I think everything below 10,000 we can't do anything about. So I think I do need to think about it maybe a little bit differently. So you would try that then, so we could train it separately and test it
Mhm.
separately and just
You can even
yeah.
do it with like the
So
brain age
yeah.
models too, like the UK
Yeah,
Biobank brain age
yeah, we have
models.
done that, but there we didn't see much of a difference. But that could
Okay.
also be because it's so much data that it just
Yeah,
falls
it's like
back to a
learning
mean,
one thing. Yeah.
Yeah,
Mhm.
yeah, exactly. Yeah,
Cool.
but there are lots of interesting ways of probing these things, I think, in the models.
I
Yeah,
also struggle with the lack of data. So, all right, I'll stop talking.
yeah.
I'll jump into some of our, oh, sorry, Magda. I was just going to get
no,
to some of the questions in the
yeah,
Q&A. We've
go,
got
go, go.
Melissa Wright saying, thank you for such an interesting talk. I was wondering if you could speak more about the cardiometabolic and brain health relationships in the context of metabolic disorders like PCOS and diabetes.
Oh, not really. I am not an expert in any of those, but it's definitely relevant. I think it sort of tends to pop up more and more, even in the relation to depression, I think, in women. but I don't think I have any like good answers, or I don't want to say something just to say it. Maybe someone else has thoughts about this, some expertise to share. Surely.
I'm going to gather that Melissa does, but we'll get her on here to share those data soon.
Yeah.
Um, and then Tamara had a really great kind of announcement. So the NIH has a research opportunity that just came out on computational models of hormone homeostasis. I did quickly check. Unfortunately, there's no foreign entities allowed in this one, but if you happen to be based in the US, this would be a good one. Really kind of pairing together AI and kind of hormone health. And then she asks, how does the model, so in thinking about your work in the maternal brain, how does the model account for age of the mother at the time of childbirth?
Good question. So age, I think, at the time of childbirth is quite highly correlated with age, actually, in the UK Biobank, which I suppose makes sense. Could be like cohort specific, I don't know. But I can't remember. I don't remember all these details from these studies, but I'm pretty sure that we had some analysis where we looked at age of first birth, where we didn't really find anything of any interest. But generally the brain age model is just MRI data and age, and then you correlate that with whatever else. But it does become a little bit tricky when you look at things that has to do with age, like this one. So I don't know how else to respond other than yeah, I can dig it up and send it, this paper. There is an analysis in there in terms of age of first birth, but I'm not so sure we could make much sense of it because of how correlated it is with age, and obviously brain age as well correlates with age. So yeah, it's quite complex.
I don't know, Meg, if you had anything to add on that, if from Susanna's
Yes.
sample, you guys have looked at age of the mothers.
Emily, you asked me? Sorry.
Oh yeah, I was just wondering if you had anything to understand whether age of childbirth had noticeable effects.
In our studies, I think we include age of the mother, but not, I mean, because we are like exploring that like short window of pregnancy, we use just age. And we've never seen that age has a significant effect on the brain changes. Yeah.
Was there a recent study though where there was something about first time versus second time mothers? Something, yeah.
Yeah, it looks like the second pregnancy also has the same effect but less pronounced. Elseline has just published
Yeah.
Elseline Huexema.
Mm.
Um,
And
I had
oh,
I had
sorry,
another
Sue.
quick question. Sorry, Emily. Anne-Marie, you talk about different methods for global versus regional effects. I was wondering, what did you do for the parity article? Because you see like the most significant regions are these subcortical regions. How did you do it there?
So in the first study where we did this, we did regional brain age. So we had clusters first, and then I think we ran one model for each of the clusters. I'm going to be honest though and say that if I was to do it again, I wouldn't have done it, I would have done it that way. And the reason for that is that the performance tends to drop. And that doesn't necessarily have to be an issue, but I think I get a bit nervous about what these brain age values mean if the main model of brain age isn't particularly accurate, if that makes sense. So I think that ideally you have a brain age prediction model that performs really well, and when you look at your deviations, you know what you're looking at, kind of. but if your main model is less accurate, I don't know, I'm uneasy about it. I don't know how else to explain, but I think the paper that we wrote in 2024 was kind of me choosing not to do the brain aid on top of the clusters for this very reason. And thankfully it lines up, right? So I think it's kind of nice, but there are many things to keep in mind in this modeling sphere of things. So I would recommend maybe trying both if you can, right? And you could just look at the cluster volumes directly instead of running brain aid on top of it, for instance, yeah, if that makes sense.
We have some other questions. Udipa says, fascinating data with body fat. It's possible that higher adipose tissue in older women, especially those more than 80, is associated with less frailty and presents as protective. From a meno perspective, adipose tissue is more a driver of estrone as opposed to estradiol, which has pros cons on brain age or other factors. Lots of nuance.
Yes, agreed.
And then Caroline Smith says, how are trans people handled in these models? Are they a different category, absorbed via biological gender instead of chosen gender, or eliminated? I imagine that they would be very interesting considering they will have been exposed to heavy doses of sex steroid hormones with a very defined start point, dosage, and duration.
I agree. There is no data on this at all. We only have sex binary, I think. So that's not great. And I guess a lot of people are working on improving that across the board. But here, yeah, we don't have any, unfortunately, we don't have any information on this now.
Good point to create, other data sets that account for this.
Yeah, definitely.
A follow-up question. Women tend to have increases in autoimmune conditions such as thyroid or rheumatoid arthritis, psoriasis, etc. Are these issues taken into account yet into the models, or is it planned? I know that in stroke studies, women with thyroid disorders and B12 deficiencies are often excluded on purpose. Considering how many women are affected, this accounts for a large cohort being excluded.
I think in some of our studies, we do exclude anyone who has some kind of condition or disease that would be known to influence the brain. Pros and cons about this, definitely. I think sometimes we're restricting ourselves a little bit more than what we maybe want to as well. But I guess with the brain age modeling, some of the thought there is to have the brain age across a healthy sample. But at the same time, what is representative, what is normal, what isn't, I think there are many ways to do this, many things to keep in mind. I must also say that we have seen very little difference actually, whether we include people with depression, autoimmune disease, etc. And I think again it's because the data sets, especially the UK Biobank, is so large that the mean will sort of be where the most of the data will cluster anyway. But I think it's still a very important point though, and lots of things to keep in mind in terms of co-founders and different groups of women.
I think Caroline Schmidt has a question. Based on your brain age models and work with UK Biobank, do you want to go on record? Do you want to say anything about sort of menopausal hormone therapy? What are you seeing about this?
Do you want to go on record?
Or not? But sort of, can you weigh in on how menopausal hormone therapy may or may not influence these markers of?
Yeah, I think it may or may not influence these markers is basically the answer. We have studies on this, and Claudia has done a lot of work with the UK Biobank prescription data too, to try to figure out. Yeah, it's been difficult to interpret many of those results. There are a couple of papers. Maybe you want to send them around. eLife paper that you're also on, Emily, I think is a really good one to read, where we can't really, it's so complicated, but it definitely looks like the effects of hormone therapy depends on medical history, possibly also, was it age? I can't remember anymore. There are so many analyses in that paper. But overall, we don't see anything like big or conclusive, I would say. I don't know. Do you agree, Emily?
I totally agree. And I have this link copied, but now I'm not sure if I can. Oh, here's the menopause. Oh, no, I can only send it to panelists. Anyway, if you just Google menopausal hormone therapy and the female brain in eLife, yeah, we published a paper just last year, I guess.
Yeah.
Where we sort of go through the nuance of this. And with all things, it's not straightforward. There's nuance to it.
And I would also, just to add to that, I think look up studies from Claudia's PhD student Hannah as well. Some interesting brain age genetic stuff and hormones. Yeah, so generally just go and watch Claudia's next talk, I think, and hopefully she can go into detail here, because it's quite interesting to just not very conclusive, unfortunately.
And we'll do a whole talk on that kind of in some of the seminar series coming up here. So with that, I just want to thank everybody. I think all 110 of you who signed on, just incredible questions, and this reaches such a broad audience of clinicians and scientists and community members. And so, Emery, we're so honored that you could share your beautiful work. You have built such an incredible portfolio. You're using increasingly sophisticated tools to ask really hard problems. And, on behalf of women everywhere, we're so grateful that you're using your time in this way. And thanks to everyone listening.
Thank you so much. Thanks to you guys.
All right.
Thank
Bye,
you.
everybody.
Thank
We'll
you.
see you
Bye,
next
everybody.
Bye-bye.
Bye-bye.
Bye.